Good morning. I'm Dr. Ali AbuRahma, and I have here with me Dr. Enrico Ascher and Dr. Malas from University of California. Today, we're going to be covering hot topics at VEITH meeting 2019, and that's TCAR, transcarotid revascularization. Where do we stand with TCAR today? Dr. Malas.
Thank you, Ali. The question first is why TCAR? So far we've been doing really amazing job with carotid endarterectomy, and carotid stenting was introduced to be minimally invasive option for patients who are high risk for endarterectomy. But every single clinical trial showed a stroke rate twice as much with transfemoral stenting comparing to carotid endarterectomy. So TCAR is this hybrid procedure that combine the best of two worlds, endarterectomy and stenting. It gives you CEA-like protection by going directly through the carotid artery and clamping the carotid artery. And the most recent evidence showing the lowest reported stroke ever compared to any transfemoral stenting, as low as 1.5%.
Dr. Ascher, I know you have published and have great experience in what we call mini-incision carotid endarterectomy, and you could do the procedure, clean the carotid artery without leaving a device behind. Give us your thought about, would this replace mini-incision carotid endarterectomy? Yeah.
Thank you, Ali. I think this is a great question, and it's very, very timely, because carotid endarterectomy was developed in the 50s, and since then really not much have been done in terms of evolving the technique. In 2005, actually in 2000, we felt that if we are to compete with carotid stenting, carotid endarterectomy has to change. And the first thing we did is we got an ultrasound machine and we identified the location of the carotid bifurcation. So therefore, we could limit now the incision. We don't have to make an incision from the earlobe down to the upper chest to find the carotid bifurcation. So just using this simple maneuver, you can now limit your incision to about 1 inch, or a bit more than 1 inch, or a bit less than 1 inch, but 1 inch in average, and you can go to this area of the carotid artery and do the endarterectomy the standard way, or with eversion endarterectomy. You have the options. We also use a very cheap way to see whether the patient needs a stent or a shunt or not. You just measure the back pressure, and this has been shown to be accurate over 2,000 cases. So by doing a small incision, which is almost the same size as the incision you do for TCAR, we can avoid the stent, makes the procedures cheaper and is as safe. Not that TCAR is not indicated in some patients. I think those who have a high lesion and those who redo operations certainly would benefit much more with TCAR than any mini incision.
Thank you, Dr. Ascher. Dr. Malas, on the same token, listening to Dr. Ascher, you are cleaning the artery with an incision close to, almost similar to the incision of TCAR. So what do you think TCAR would offer if you do that type of approach and you don't leave any metal behind?
I think if you can do carotid endarterectomy with 1 inch, that's phenomenal, and not everybody as good as Dr. Ascher. The reality is we see, on average, the incision at least 2 to 3 inches, and that's considered small. Yeah. A lot of people will have an incision that is much, longer, and you still also, a majority of us do this procedure under general anesthesia, and that is one of the problem with carotid endarterectomy. Is not the procedure itself, is the sequelae of the anesthesia, risk of MI. So I think, carotid endarterectomy is the gold standard, is the way that to remove the plaque completely, the source of embolization. But TCAR, the more we see an outcome that is similar to carotid endarterectomy for the first time with stenting, and the fact that you can always do it with very small incision, 1 inch, it's going to be more and more one of the options available now for our patients. And I totally agree with Enrico. There are certain patients that definitely will benefit from stenting, clearly with all the data, including also my radiated neck and prior neck dissection and whatnot, where it's clearly stenting is superior.
We have been saying lately, well, the TCAR is almost as good as an endarterectomy. If it's not good or equal to, but aren't we probably comparing different type of population? In other words, I would like to hear from Dr. Malas, is there a select group of patients where TCAR work well, but there are select certain patients who really cannot be TCAR candidates?
Yeah. Yeah. So the first part of the question, you're absolutely right. That's a very, very important point. So with the TCAR surveillance project, which was sponsored by the SVS and the Vascular Quality Initiative, and it's a clinical trial approved by the FDA, we enroll every patient who had TCAR in this country, and we have data on all these patients. And these patients are extremely sick. So the people who are getting the TCAR are not similar to the people getting carotid endarterectomy. All of them has to be high risk, whether it's medical high risk or anatomical high risk. And these patients still having similar stroke and death rate compared to endarterectomy, and half the MI. So just to kind of emphasize the point that you're talking about as far as the patient. Now, anatomically, not everybody can get TCAR, so you have to have a healthy common carotid artery because you have to access the common carotid artery directly. And you have to also have a good diameter of the vessel, at least 6 millimeter. You have to have landing zone, which is the distance between the clavicle and the bifurcation, to be at least 5 centimeter. So these are a specific, anatomical requirement for TCAR. The second more important thing about stenting in general, we know that there are certain lesions that don't do well at all with stenting. So if you have severely calcified atherosclerotic lesions, circumferential calcium, the thickness of the calcium is more than 3 or 4 millimeter. These people don't do well with any kind of stenting, and endarterectomy is the way to go with these patients.
Professor Ascher, what's your thought on this point?
I think they're very good questions, and I don't think we have definitive answer because there haven't been done a study comparing mini-incision carotid endarterectomy with TCAR. And I think that's what we need to think about. Yeah. A prospective study comparing a much cheaper technique, which is as effective in my mind, but I'm biased, versus one that's more expensive and that harbors a metal at the end of the day. So I think that has to be answered with a prospective study. But I think your point is that for TCAR, of course, you have to select. There's a lot of selection in the process that goes in, like Dr. Mala said, and I would assume that probably 20–30% of the patients are not really candidates for TCAR. While the patients that I think they're not candidates for mini incisions are only the ones that have a hostile neck. And those are probably less than 5% of the cases. So I think right there, you're going to have to use, perhaps you have to know both techniques. Yeah. I think they both would add to the armamentarium to the vascular surgeon.
The concept of reversing flow is confusing to many clinical surgeons about how could you have reversal flow, which, as you know, it average 8, 9, 10 minutes. Knowing the fact, some people think there is no flow to the cerebral hemisphere of that side, and now we say the stroke rate is 1 or 2%. Do you think maybe that impact on their cognitive functions in the future?
Yes, a very important question, and I think that's one of the advantages of TCAR is that you're not stopping the blood flow. So even though you're clamping the carotid artery, you're actually allowing the blood to flow continuously through the contralateral carotid and through the vertebral artery, through the circle of Willis. So, and this is why you have to have an 8 French sheath to allow enough channel to get the blood to flow retrograde while you're doing the procedure. So first, you don't manipulate the lesion, you don't pass any wires without protection, so you have continuous protection throughout the procedure. Second, the blood is not stopping to the brain at all, as it happened with carotid endarterectomy when you clamp. So the blood is flowing, but instead of going antegrade, it's going retrograde, and the tissue in the brain is being well perfused. And this is why what we're seeing is, now, to thousands of patients, that less than 1% not able to tolerate this. And these are very few people who have like an M1 segment or any occlusion within the circle of Willis in that area, that they don't have enough collateral flow from the anterior communicating, posterior communicating cerebral artery.
Yeah. Dr. Ascher, your thought about this point?
I also agree. That's a very good point, except that cognitive dysfunction can take years to show. It does not necessarily show on the spot. You may have somebody who talks normally right after the procedure and has no motor dysfunction, but yet has grave cognitive dysfunction that may show years down the line or months down the line usually. So unless we do a a very good scientific study with cognitive testings before, during, right after, and then down the line, perhaps in a year or two, we won't really know the answer. Because there's microembolization that can occur, although this technique, the idea of reversal, is very attractive to me. Actually, something that was brought up by Parodi and his colleagues some time ago, and I think is a great, probably the best way for protection, because when we shunt the patient, actually, we have a chance of embolizing during the procedure, of creating some technical issues with it. So I think the reversal, actually, a portion of this procedure is very attractive to me.
On the same talking, since you said that's why we have the 8 French carotid sheath, and first time we have done this over 2-3 years ago, I have in the first few cases some difficulty getting that sheath in, and the principle was, as you suggested, to have a good reversal flow. Do you see in the future that being going down to 6 French, where we have reversal flow, but it's much friendly in putting that sheath in the common carotid artery?
That is very important. So as you know, the stents now can be delivered through 6 French and even 5 French some stents. But the problem is that in order to achieve this robust reversal flow, so all the testing that was done on this procedure in research labs and bench models shows that in order to have an effective flow reversal, you have to have at least 8 French inner diameter. Now the sheath have dramatically improved, and you can really deliver it, and there's a few tricks, to dilate the opening and to have enough purchase with the wire that minimize the risk of problems of advancing the sheath.
Okay, so it looked like we covered most of the good point that many clinicians raise in terms of TCAR versus no TCAR and so forth. Yeah. I think it looked like we got into answering many of the questions which goes around TCAR. But today, in November 21st, 2019, you had beloved person, mother, VIP, and they need a carotid intervention. What would you recommend for them feeling comfortable with that decision? And they can have any of these procedures. What would you recommend, Dr. Meraz?
I think, first, the most important thing about us as vascular surgeon is that we own that field, and we know the pathology of carotid disease, and we need to be expert in all different treatment management.
I understand.
And I think, the way I look at every patient, what would I do if it was my mom or my dad? That's how I make decisions. And I think the first thing, if they're, a lot of patients really don't need anything. They just need a good medical management, statin and aspirin.
We understand that.
Yeah, and if they need the procedure and they're fit medically, carotid endarterectomy is the gold standard today. We have data for 60 years, and we cannot just, based on 7,000 patients, change the way we do things. We need more studies, more trial before we can make such a leap. But the data so far, I think, if my mother, and I know my mother have a lot of medical problems, she will be better fit with stenting, and absolutely will not be transfemoral stenting. It will be TCAR.
Dr. Ascher?
Right. I will send that loved one to you or to Dr. Malas for carotid endarterectomy with a mini-incision.
That's a good
I
point.
have no doubts about it.
Yeah, I understand your mother might have multiple medical morbidity. I was trying to say you have someone who's healthy and can fit all these procedures. Would you really do an endarterectomy? Of course, it's a great idea with mini-incision by Dr. Ascher. Or would you still do carotid stent? I personally still, today, I would go with the endarterectomies, but I do know we have a lot of patients in our practice who would be an ideal candidate for TCAR.
Well, it is the gold standard.
Yeah.
And you cannot just do TCAR on people who are not high risk, because you have to do it under clinical trials. So the answer is carotid endarterectomy.
Yeah. Thank you very much for being with us today, and I hope we could learn more and more about these advanced technology in the carotid field. Thank you very much, guys.
Thank you.